Good morning. Good morning. My name is Stephen Su. I am honored to be here at the NATMA 2016 conference. I actually received the NATMA scholarship a number of years ago and hope to contribute to the second generation involvement in the future. That's something that is excellent, and I'm so happy to be here. Just to be a little bit of introduction on myself, after finishing the physical medicine and rehabilitation residency at UCLA. So that leads me to the talk. The talk is spine rehabilitation management and spine surgical screening. Multiple objectives for this talk, but number one, review the prevalence of lumbar spine pain and just talk about how it affects everyone, and it's, I think I tried to pick a broad topic that could be relevant to a lot of people here. Review the trends of surgical and non-surgical management, and in my opinion, there's been some very concerning trends, and so that's something that I wanted to review. Review decision-making and referrals for surgical consideration, or when to make that referral. I think that's important. And then also review other spine treatment and rehab modalities that are available, because I think that one thing is people have back pain and want to see a spine specialist, and a lot of those spine specialists are surgeons, and surgeons are incentivized to do surgery. So I just want to let people know that there are a lot of data and modalities out there that are other options. Lumbar pain is very, very common. It's the 5th most common reason in terms of diagnoses that are seen in physician offices currently. In everyone's lifespan, most people will have back pain, so over 85% of people will have significant back pain at some point in their lives. The good thing is that 70 to 90% improve within a 6 to 8 week time frame. And even higher if you give it more than 6 to 8 weeks. But the other problem is that recurrences can happen, which it's still shown to have a good outcome total, but 50% of recurrences for lumbar pain can happen within 6 months and 70% within 12 months. So very common, and I think probably has affected most people in the room. In terms of trying to find ways of evaluating, I think that there are a lot of people in primary care and just as consultants outside. I make a very big difference of differentiating acute lower back pain versus subacute lower back pain and chronic lower back pain, with chronic being over 12 weeks or longer, so 3 months or more. The reason I differentiate is, number one, acute lower back pain, whether we do something or not, and I think that there's a lot of things that we can do to improve the quickness of it, but regardless, as with the last slide, over 90% will resolve from the acute back pain no matter what we do. The most concerning, in my opinion, is the 5 to 10% that develop chronic lower back pain because a lot of the modalities and treatments are available are very costly and can or cannot show effectiveness, so it's something that we're reviewing. And the other thing is to differentiate if there's any red flags that are associated with the back pain. Most people have what we call mechanical lower back pain, so back pain at the back and things, but if there are concerns of any, what I call red flags or neurologic deficits, so any weakness or progressive weakness that's happening, oftentimes that's seen as a foot drop, difficulty walking, weakness getting up in bed, or having issues with incontinence, bowel or bladder symptoms, which falls under the category of taiwanus symptoms. And then the subtle one that we can see in clinic quite often is just subtle reflex changes and distribution pain that you can catch some of those things. So the reason that those are so important in identifying is it's harder to generalize a patient with those symptoms into just acute or chronic categories, because they may need to be seen more urgently, and your responses to surgery and thus are actually much more effective. This is a study that was done by us at Cedars-Sinai. This is reviewing actually the trends of lumbar fusions, actually all fusion surgeries of the spine between 1998 and 2008 from public data. A large increase in cost and the use of fusions after that time frame. So I think one of the things is understanding that there is financial incentive by the surgeons for these procedures also. I think this is an important slide also. There's two graphs. The graph on the left side is showing what we've been talking about, that spinal fusions have increased in the last decade, and this is by a 3.3-fold increase. It's actually also comparing it to other comparable surgeries out there. So besides that, comparing it to hip, because all surgeries are increasing, but compared to hip replacements and knee replacements, it's happening at a faster rate. Even compared to cardiac procedures like coronary bypass surgery, it's happening at a faster rate. And on the right side, it's actually the even more concerning slide to me, because not only is it increasing at a faster rate, the expenditure and cost has increased 7.9 times from 1998 to 2008, and I think that trend has continued to increase even after 2008 till now. We're working on another 10-year study, but that won't be done for another few years. So just to talk about that, there's reasons for this trend. I think some of them are reasons for increasing procedures across the board from orthopedic surgery or other surgeries. We have an increasing life expectancy of the population. We have improvements in diagnostic imaging and diagnosis, so we're able to catch more things than prior. We have an increased availability of spinal fixation devices, and more people are being trained, so there's an increase in availability of doctors also. I think that this is even though my data was showing 1998 to 2008, I think that's the wrong expectation, and I think that's the wrong, people are set up for disappointment if that's what they believe. Because all the studies that have shown those improvements on pain and disability have all been associated with neurologic deficit also. This study is actually a relatively new review article by the Cochrane Review. So it was published in 2006, or this year, January of 2016, and it looked at over 30 articles, which was reviewing specifically. So this is a very large list. And the point is not, you could actually give a talk on each one of these topics, but the point is not to give too much specifics, but the point of this list is just to show that there are a very number of researched, with varying degrees of effectiveness, of strategies and modalities that are out there to treat spine pain or other types of pains that is outside of surgery. And going back to the idea that there's a high percentage of adverse side effects that are possible with the surgeries, it's definitely something to consider prior to ever thinking about that. Therapy injections, but all these are other options that are available that are more progressive and newer that are trying, in my opinion, to avoid surgery. So part of the talk here is also to just talk about how important exercise, activity, and lifestyle is. Common and most researched thing out there, and most physicians that see come in with back pain will refer you to a physical therapist. Physical therapy, studies across the board, in my opinion, have definitive improvement in decreasing disability, decreasing pain, increasing range of motion. There's even subtypes of care, different types of therapy. They have been shown to be effective and sometimes very expensive, but been effective in, decreasing pain and decreasing pain perception. Multidisciplinary rehab is the same type of thing, even involving vocational rehab, finding the right job that can fit your restrictions and modifications for your back. And I think that's truly more so been shown to improve balance and decrease falls, but that in itself is an effective way for exercise and mobility and incorporating that. A deep tissue massage is better, but the data has shown that, like, in combination, those things actually can decrease pain and can be cost effective. I think that's an important. I know, unfortunately, insurances don't cover a lot of these services, but has been shown to be cost of those things. I think it's important to identify red flags and neurologic deficits, because those are the patients that's going to benefit from those invasive plans, and those are the people that you should get to have surgical consultation, but that there should be consideration and encouragement in other rehabilitation and non-surgical management, because depending on your study has shown to be as effective as surgery. And so also that there are increasing available.
Very good speech. 大家都活得越久越老呢，那个 spine 的健康是越重要，所以希望大家都听了以后呢，会更健康、更快乐。谢谢。
我想问一个问题哈，这个也许跟这个没有关系，但是呢
In English.
No, in English. I'm sorry. I have a simple question. Weightlifting, low weightlifting, say 5 pounds, 10 pounds.
Actually make their back pain worse or increase their likelihood of having a back pain exacerbation. There have been a few pretty good studies that have actually shown that the exercise can increase pain perception for a small amount of time, but there has been definitively no evidence that those recurrences happen at an increased rate, whether you're doing the exercises or not. But they do improve the timing that you'll improve, so that's why I'm supportive. Did that answer your question?
Yes, thank you.
Okay, and one more.
Sorry, because the time, limit. Otherwise, nobody can eat lunch. Okay? A wide spectrum of disease. Thank you.
Professor, get his stuff ready. I have one more to tell you about Stephen. Stephen Xu, his parents are here. I want to support Nama, very, very important person. He is a Dr. Child Xu. Can you stand up? And for everybody to know you. And Stephen's mom, Jennifer, is our post-convention tour director. Jennifer, would you stand up for us too? So you're on the front. You are very outstanding. Thank you.
他小公用台语 but I don't think all of you are going to understand. Well, here are my financial disclosures. I am a consultant for a lot of companies, a lot of research disclosures as well. But the only relevant disclosure for this talk about Asians and glaucoma is that I'm an Asian. They tell me that. Okay, so the reason for all of you to pay attention to this talk is that your patients and all of you will get one of these diseases. One or more of these diseases. In fact, many of you have already had probably cataracts and that cataract surgery, and your patients will have had that. So this is one of the reasons. Glaucoma is a very common disease, but that is not really reversible. So I think that will encourage you to kind of listen, and your patients, many of them will have it as well. Retinal disease is very common. Macular degeneration is much more common among white people. Leading cause of blindness in the United States, diabetic retinopathy is the #1 cause of blindness among younger adults. And it's increasing, obviously. All of you know that better than me, that there's more and more diabetes, so we're having an increase in this. This is because we're living longer, both of these diseases, as well as macular degeneration. Let me tell you a little bit about the ocular anatomy so you understand these diseases and what we'll be talking about. Here's the front of the eye, here's the back of the eye. Here's the cornea, and here's the lens, which becomes the cataract. So when we're young, that lens looks very clear. So those of you who are maybe under 40 in here, probably a very clear lens, but if you're over 40, like I am, it's already starting to form a cataract. And that means it's getting more yellow and more white, or both. And then it's progressive, and over time, by the age of 70, most of us need cataract surgery. It's out. So, you know, you're gonna have to take this out. The surgery is very modern. It's in and out surgery. You go in, you take it out, you put a new plastic lens, and you see better. And glaucoma, what I'm gonna tell you about glaucoma is that it's a disease where the pressure is high inside this eyeball. So it's like a basketball that has been pumped too high, and the pressure is damaging the optic nerve. I tell my patients it's like the thumb. Your thumb was squished right at that optic nerve and damaging it, and usually you lose peripheral vision. So glaucoma is the leading cause of irreversible blindness in the world. What's the leading cause? The leading cause of overall blindness is cataracts, which, as I said, everybody's going to get, including in this room. And then we can treat that, though. It's reversible, it's treatable. The second leading cause of blindness in the United States is glaucoma. The number one is macular degeneration, because there's more white people in America than any other type of people. We divide glaucoma into open angle and closed angle. This is very relevant for Asians, because Asians get a lot of closed angle glaucoma, in relationship to overall among white people, for example, it's almost all open angle glaucoma. Here are some of the differences among races, just to give you a broad overview before we talk about Asians. African Americans have 4 times more glaucoma than whites. So if you're African American, or if your patient is African American, then you have about a 10% chance of getting glaucoma than whites, which is only about 2 to 3%, which is not a rare disease. It's just much less common than in African Americans. Hispanics are somewhere between the whites and the African Americans. They're about 5 to 6%, and Asians, us, we're about 2 to 5% of us will get glaucoma, which is not. And that all these numbers, by the way, are increasing because these are age adjusted. But the truth is, we're all probably going to live closer to 80 years old and maybe older. Chinese have a large amount of the closed angle glaucoma, ethnic Chinese. Koreans and Japanese, interestingly, even though white people look at us and we all look the same, it seems like we're not all the same, right? The Koreans and the Japanese have mostly normal tension type, and how is that relevant to specifically us in this room? We are gravitating more towards the Korean and the Japanese in the sense that we're getting more and more normal tension type. And I'm going to show you why that is. One of my colleagues in Taida, in National Taiwan University, who is the most famous glaucoma specialist, he has a theory as to why there's this discrepancy. Japanese and Koreans are more industrialized, and so is Taiwan. And so now you've taken a population and you push them more towards myopia, because if you look around, most of you are wearing glasses. In fact, to get into ophthalmology, it's almost a requirement that you wear glasses. And so most of us in Taiwan are actually myopic, and I'll show you in a little bit. And so that's moving us farther away from closed angle glaucoma, this normal tension type where the pressure is not very high, but it's almost like the nearsightedness is causing the glaucoma. And next. So again, kind of the anatomy and basic anatomy for glaucoma. In a normal eye, you have a normal pressure and the fluid goes out where it's supposed to in the front, and you have a normal optic nerve where the healthy tissue, you have a little bit of an indentation at the nerve. But in glaucoma, it's, again, I kind of tell my patients, it's almost as if somebody stuck their thumb into their optic nerve and squished their optic nerve. That's sort of the mechanical theory of glaucoma. It's probably more complicated than that. It's probably more ischemia, the pressure is leading to less blood flow to the optic nerve, but it doesn't change the fact that the only thing that we can change is to lower the eye pressure. Next slide. So what does glaucoma do to you? It's a disease that is very sneaky. I think a good example would be like high blood pressure, and most of you or many of you treat high blood pressure. For your patients, you know, they come in, they feel okay, they're still walking and talking, but when they get a stroke, it's too late. It's a little bit like that in glaucoma. Again, it's a pressure problem in both, right? Because the risk factor in for strokes is high blood pressure. Here, it's high eye pressure, and it makes you lose your vision peripherally first. So you don't really see black, but you just don't see peripherally very well, and it slowly kind of creeps up on you. The problem is that if you and I had glaucoma in this room, we wouldn't really know it until it's too late, because the peripheral vision we don't use very much. If we look at each other, we look at our central vision, we look at each person's face, and it's the central vision. So it's a disease that you have to detect. Again, like high blood pressure, if you don't get it checked, you don't know that you have high blood pressure. Go ahead. So I'm going to go into the anatomy a little bit. This is a cartoon. I know it doesn't mean much to you, but this is the front of the eye, the cornea. Here's the lens again. Here's the iris, which for all of us is going to be dark. And the fluid is made in the ciliary body behind it, and it goes through this area called the angle, we call it, because it forms the corner of a triangle. And I'm telling you all of this because it's relevant to the types of glaucoma that Asians will get. Next slide. And so I flip the eye over here, and you see in an open angle, here's the anatomy that you see a little bit more in color here. And here's the angle where the fluid goes out. The $64 million question in glaucoma is, what is it about this angle that is getting, changing on a molecular level so that the fluid can't get out and the pressure goes high? But for the type that is very common in Asians, where the angle is closed, you can tell this anatomy has suddenly become closed off, where the blood vessel that it needs to get to is closed off. This can be an acute attack. I'm sure in Taiwan and Hong Kong, other countries, there's very commonly acute attacks. Actually, my Hong Kong counterparts do a lot of research in angle closure glaucoma. One of the treatments actually is to take out the lens, almost do early cataract surgery. As you can tell, the lens here is positioned more anteriorly. In an occludable angle, this is an ultrasound of the eye. Again, a little bit of that anatomy, that angle that I was telling you about in this patient is very narrow. We'll take a look at the next one. And the next one, the angle is almost closed here. Here is the cornea and the iris. And then the next one, you can do a laser procedure in which you make a hole in the iris, because usually the cause is that the fluid is building up behind the iris, this is sort of looking en face at the patient, and the fluid is building up behind, pushing the iris up and causing the angle to be closed. So a simple treatment that could in fact almost prevent most of this closed angle glaucoma is to do a laser procedure in these patients, but you have to catch the right patients. You can't do it in everybody. It would be like trying to catch or trying to prevent a stroke by treating everybody for high blood pressure. Go ahead. And this is just showing anatomically afterwards that the angle is opened up in that same patient I showed you before, just by doing that laser iridotomy. Go ahead. So how do we diagnose glaucoma? What does your ophthalmologist do? What do you need to know about when you tell your patients, oh, I'm going to send you for, a glaucoma checkup? Well, it's relatively simple. We check the pressure in the eye, a little bit like checking, blood pressure, checking the blood pressure. We check the optic nerve. We do a test on the visual field, and then we're supposed to do gonioscopy, which is this test where you put a lens on the eye and look at the angle. Next slide. Here's the eye pressure check. Many of you are accustomed to the air puff test where there is no contact. It's okay, it's not very accurate, but the more accurate one is where we actually touch the eye and actually get a direct measurement. Next slide. And then we look at the optic nerve. When we look inside, I'm sure most of you have purchased or used an ophthalmoscope, and you look in, and usually you don't know what the hell you're looking at, to be honest, but hopefully I can educate you, is that you're looking at the optic nerve, and hopefully you'll see a small cup. Again, you're more likely to see glaucoma than you are, say, papilledema, although that's usually what we're often looking at, where we're looking at an obscured optic nerve. And in early glaucoma, that cup, that central white area, becomes larger, and in the end, almost all of the nerve is just the central pale area, which means it's all cupped out. The nerve tissue is actually gone. Next slide. And then again, it's a sneaky disease, so you have to do testing, including a visual field test. I think many of you have done it, where you have to hit this button every time the light flashes in this machine. And then we're testing your peripheral vision. The normal result is like this, and an abnormal result is typically like this, where part of your peripheral vision is getting lost. Not just spotty, but a little bit here, and then it expands from there. And again, you wouldn't know it, most of your patients. So population studies have shown that more than half of the people with glaucoma don't know it. So your job, I know most of you are not ophthalmologists, is to be aware of this. If they have a family history, if they're African American, other risk factors. And now it would also be for us who are in the Asian community, my high myopia. With my thick glasses, I'm at higher risk for glaucoma, for example, to send those people for exams. Next slide. And then the gonioscopy is putting a lens on the eye and actually looking into the angle, looking to see if they have a shallow. Next slide. So normal tension glaucoma, now that I've told you about glaucoma as a disease where the pressure is high, causes damage to the nerve, makes you go blind, now I'm going to give you the exception to the rule, which is that in glaucoma, you can have cases where the pressure is actually in the normal range. As I said, for the Japanese, most of their glaucoma is the normal tension glaucoma, which makes it very difficult to detect as well as treat. So they have a lot of research going into how they can treat normal tension glaucoma. Another analogy for those of you who would say in neurology or just in internal medicine, it's a little bit like normal pressure hydrocephalus, right? If you have hydrocephalus and you have a high pressure in the brain, yes, that's going to squish your brain and damage it. This is like the normal pressure hydrocephalus. The pressure measures normal, but you're still getting atrophy of the brain. How can we help that? Maybe with neuroprotection someday. Next slide. So the treatment, the only FDA-approved treatment we have is to lower the eye pressure. This neuroprotection I'm talking about, I was principal investigator for UCSF for one of the largest studies. Unfortunately, nothing's been proven yet, and I'll probably have a slide, oh, that's right here, but I have a slide on that as well, is that we only have ways to lower the pressure, including medically, eye drops, surgically, with laser and incisional therapy. For those of you who have patients with glaucoma, but you're treating them just as for in their internal medicine care, please, when they get admitted to the hospital, make sure they get their eye drops. Because at the other end, at the ophthalmologist end, we often see people who got admitted to the hospital for 1 or 2 months, and the last thing that the nurses or other folks worry about is those eye drops. Well, God, they had a heart attack, you know, what do we care about the eye drops? Then they come back and sometimes they're blind in one eye from glaucoma, or they're just much worse, and we realize, boy, you know, I mean, everything else they usually write down, oh, they gotta get their Lasix, they gotta get their, you know, their Coumadin and everything else, but all the eye drops, those don't matter. So please make sure to make sure their eye drops are written for. Next slide. So what do we do with the eye drops? Just if you're curious, I'll go through some of them. Just to give you a broader view, as a glaucoma specialist, I kind of see myself as a plumber, because we're dealing with fluid flow in and out of the eye, so I'm only trying to enhance that flow. So surgically and medically, I'm basically a glorified plumber, a highly paid one, thankfully. But we have outflow and we have inflow. So we have drugs, some of which, many of which you know, beta blockers, alpha-2 agonists, these are used for treating blood pressure, calcium carbonic anhydrase inhibitors, which are diuretics. These decrease the inflow. Outflow include prostaglandins, cholinergic agents like pilocarpine. We'll get the next slide. I'm going to go through each of them a little bit just so that you're familiar with them, but just very briefly. These have become the #1 class. This is the #1 drug from Pfizer. It's gone generic. Prostaglandins have a very interesting history. I won't go into it in detail because I got to get you guys to lunch. But the other thing is that it has a very interesting side effect. It lowers the eye pressure. Obviously, that's why it's on this list. It lowers it very well once a day. But it has the side effects of making your eyelashes grow longer. So I think, yeah, most of you probably have heard that, you know, that there's this, and maybe some of you, especially dermatologists, others in the more cosmetic field, have had patients ask about Latisse. Well, Latisse actually is a prostaglandin drug that is from Allergan, which is an eye company, an ophthalmic company, and it's actually for glaucoma. And a side effect is that it grows longer lashes, so they patented that, and obviously they're selling a lot. They have movie stars who advertise it at our academy meetings, and I'm sure some of your patients may have asked it. It's a little bit like Botox, right? And Botox is actually from the same company, from Allergan, and ironically, Botox was discovered by an ophthalmologist for the idea that it would not have the eyes, you know, for straightening out the eyes. So weakening the muscle that is in a way overacting so that the eyes can become straight. It's a very interesting story, but I'll give you the punchline. That ophthalmologist who's in San Francisco and sold it to Allergan, sold the medical rights of Botox for $10 million. Instead of getting the usual 15% royalties, he only asked for $10 million. If he'd asked for the royalties of the usual 15%, he'd probably be a billionaire. But when you ask him, and I know him, I said, well, why didn't you ask for, you know, wouldn't it be better if you got the 15%? Because it's $1 billion drug every year. He said, how much money does one man need? Well, for me, I need $1 billion. So, next slide. And so timolol is a beta blocker, just like your metoprolol. We have to worry about crossover and the effect. Actually, systemic drugs can make the pressure go down as well. and the eye pressure. You have to worry about people with asthma, of course. This is preaching to the converted. You guys know that. The next slide. Alpha-GAN is an alpha-2 agonist. It's brimonidine, which is basically like clonidine, and all of you know about the clonidine patch. So much of this is borrowed from the cardiovascular literature, but in the eye, it works great. Clonidine works terrible, my understanding is, for blood pressure, but brimonidine actually works great for the eye pressure, so it's one of our useful medicines for glaucoma. Next slide. Trusoft is a carbonic anhydrase inhibitor. We also use oral forms, not commonly, but often in patients who need it. Those include Diamox, you guys know acetazolamide, Neptazine as well. And these lower the eye pressure by decreasing the fluid in the eye. Pilocarpine is our very first drug. This is, again, in a way, a cardiovascular drug. It is a cholinergic agent, makes the pupil small, lowers the eye pressure by basically opening up that angle because of the action on the muscle, on the iris muscles. Very, how should I say, very many side effects, and it also is 4 times a day, which limits its use these days. Next slide. And then I talked about neuroprotection. You know, when I was a very young faculty member, I was asked to be part of this, be the principal investigator at UCSF for this drug by Allergan. Again, Allergan comes up, and they had lots of money, probably from all that Botox sales. And this would have been the first neuroprotective drug, but unfortunately, after 4 years, 5 years, it did not work. And you needed to show that it prevented eyes from getting worse in glaucoma. In all the animal models it worked, but unfortunately, in glaucoma in humans, it didn't work, just like a lot of cancer drugs end up not working. Many of you use memantine for your dementia patients, right? After Aricept, it's usually Namenda, which is memantine. Next slide. And here's just the results I was telling about. This got to the FDA trial, you know, phase 3 trial. We were very excited. This would have been, they spent $100 million on trying to develop this drug, and I really wish it worked. And I hope it doesn't discourage drug companies or others to continue to pursue neuroprotection, because there's very little neuroprotective drugs out there. Next slide. How about laser? If your patients ask you about, you know, again, having a general knowledge of glaucoma, laser is useful when you actually laser the area where the fluid goes out. And that increases, you know, outflow and lowers the eye pressure. It's very modest effect though, so I wish it was a cure, but its effect is modest, and then the effect wears off pretty soon, within about a year or 2. Next slide. Then it comes to the other aspect of my calling myself a plumber, which is that what's the surgery that I do? And I just had surgery yesterday, or not on me, but on my patients, for glaucoma procedures. And so every week I do surgery. This is the typical surgery, what we call a trabeculectomy. The name comes from the trabecular meshwork, where the fluid goes out, that meshwork area, and you're basically cutting a hole there. So what this means is, here's the front of the eye. We've reflected the conjunctiva, the skin of the eye, and we make a little square flap, and then we cut a hole, and then we put the flap back, because if you simply cut a hole, like the old days, well, the fluid will get out very easily, and then the pressure will be too low, which is not a good thing. That's a complication. The eye needs some pressure, but you want it to be on the lower side. And so this is to control the amount of fluid getting out, like a little bit like a valve. But again, if we look back at this, I think maybe 20 years from now, when we have much better surgeries, this is barbaric. This is not really sophisticated surgery. It's a little bit like the neurosurgeons putting in a stent within your back if you have high CSF pressures, and then draining to your front of your, you know, to the peritoneum. I mean, it's basically the same thing. Here you go. Another way is to do similar to that. You put a tube in the eye. And this is one of the major tubes. This is probably the best-selling one, and we do this almost every week. And then you drain out to a reservoir where that gets absorbed by the surface conjunctival vessels. Next slide. And then I'm going to get sort of to the meat of my talk, although it will be relatively short. But because I'm in San Francisco, I have a lot of different access to a lot of different Asian populations. So this has been one of my core areas of research. Next slide. So as an overview, you know, Asian Americans have really this diverse range. Again, even though we are seemingly a cohesive group to whites, you know, everybody looks the same, we actually have a very wide range of different glaucomas among these groups. And I'll tell you about that specifically for Taiwan in a little bit. Next slide. It may be relevant to yourself. The groups I have access to are Chinese Americans, Japanese Americans, Filipino Americans. Actually are the second largest Asian population in the United States. Obviously, Chinese descent is the largest population, but not far back, but just a couple 100,000 people difference in the 2010 census. And it's actually predicted that Filipino Americans will exceed Chinese Americans in a few years. And then Vietnamese Americans we had access to as well. Next slide. So we've done some studies in Chinatown with one of my colleagues there. Next slide, and I just want to show you the results here, my fellows who worked on it. But this 50% number, over 50% number, showing those who, among the people with glaucoma, that almost half of them, or about half of them, were narrow or closed angle. So that type of glaucoma that I said was rare in white is actually much more common among Chinese. Next slide. And the white bars show that it increases with age, so you have a very high risk of that with age. Next slide. And then we've also done studies in Chinese Americans. Here's some of my students and fellows. And we've looked with different imaging techniques. Next slide. Japanese Americans, as I said, have many, there's numerous Japanese Americans in San Francisco. And what we did, we studied them retrospectively. My fellow here did that. Next slide. And these are my colleagues who worked with me. Next slide. And then this big piece of the pie of all their glaucoma, the vast majority of it is normal tension glaucoma. In Japan, that big piece of the pie is even bigger, which again is unusual because let's say Caucasians, whites, it's only about 25% of the glaucoma in Caucasians. Next slide. In Taiwan, I told you I'd get to that. In Taiwan, this is not about glaucoma specifically, but this is about myopia, the nearsightedness that almost all of us in here have. The high school students, 84%, an updated study shows 90% are nearsighted, and the 16% that are highly nearsighted, like me, actually is now 20%. So this is an epidemic in Taiwan, and the reason for it is simple. It's not genetic. It's actually because you need to go out and spend more time outdoors. If you spend time indoors and you study all the time and you go to after-school programs like all Taiwanese kids do, then you become nearsighted. That's the simple reason. But it's also leading to more glaucoma. So next slide. We did a study here in the US, this is my student who broke this up, that myopia was associated with glaucoma. Next slide. And this is showing basically that your odds ratio of glaucoma goes up severely as you become more nearsighted. And I'm in this group, so I'm in trouble. I better get some glaucoma tests on me. Next slide. And we've also looked at Filipino Americans. I'm told that my time is limited, so I'm going to run through these slides quickly. Filipino Americans have some angle closure glaucoma, closed angle glaucoma, but a lot of the normal tension. Next slide. This is just showing the black bars of the increase with age. Next slide. And then one of my Filipino American students, who's now an ophthalmologist, studied this, and again, as I said, there's some angle closure, this closed angle type of glaucoma compared to whites, but normal tension was very high among this group. Next slide. And the Vietnamese Americans, this is a fellow, international fellow in Taiwan with me for a year, and she found that if you add up all the closed angle glaucoma and sort of the mixed mechanism borderline ones, it's actually, among Vietnamese, it's similar to Chinese. 40% of it was this angle closure type, which is very similar to the Chinese as well. Next slide. In Thailand, a lot of the, I have a Thai fellow with me now, a lot of this normal pressure type of glaucoma. Again, this is very variability, sort of high variability between these different racial groups. They're very different from Caucasians. Next slide. Singapore, the Malay population, also a lot of this pressure glaucoma where the pressure was in the normal range. No, next slide. And so I've already told you, Chinese and as well as the Vietnamese, about a third or more of the glaucoma is this type. And it accounts for 90% of the bilateral glaucoma blindness. So it's a much more aggressive disease as well. Next slide. And I'm going to talk to you very briefly about our studies where we looked at the anatomy to explain this. These don't mean anything to you, but I'll show you the pictures. Next slide. So this was a study that we did here in the US with Chinese Americans and whites. Next slide. And then basically, when we did this imaging of the front of the eye, this line between the white and, when you look at the central part of your eye, the dark part, that width is lower in Chinese than it is in whites. When you go from front to back, it's smaller as well. So that area is more crowded, and that angle that I keep referring to is therefore going to be smaller. And this is an explanation for it. Number two. Next slide. And so the anterior chamber area, no surprise, is the area within that space is smaller. Next slide. And then Asians have a thicker iris, or Chinese have a thicker iris, which makes this angle more narrow as well. Next slide. And ultimately, the dynamic change of the iris going from light to dark when you can have an attack is much more pronounced in Chinese, it's greater in Chinese, meaning you're more likely to have an attack. Next slide. And then this actual measurement of the area of the angle is smaller in Chinese after adjusting for everything else. Next slide. And so I end my talk with saying, when I was a kid growing up in America, I would get laughed at as having, you know, small beady eyes. And now I've done all the research to show that I have small beady eyes. So, in summary, next slide. You know, glaucoma is the main cause of irreversible blindness in the world, so it's really an important disease, obviously. And all of you have heard about it. Asians have this wide spectrum of disease. Vietnamese are very similar to Chinese. The Koreans and Japanese have almost all normal tension glaucoma. And Filipinos are sort of a mix in between of having both, a little bit of both. Thank you very much.
Thank you, Professor Lin. Give us a good talk about the eye vision glaucoma. 大家活得越久呢 ，spine 重要，眼睛是很重要。不要忘记哦，我帕拉加哦，你们有question呢，没有让你们那个 ask speaker， 因为呢，我们今天早上呢，差不多20分钟、30分钟呢迟到了，所以没有时间。希望你们 enjoy lunch。还有不要忘掉呢，下午还有3个 topic 哦，一个是很重要呢。 这个老人有关系的，所以希望你们呢，大家呢下午不要忘掉，还有 3 topic 哦 ，talk enjoy lunch。
Morning speaker, you want to come over here? And we thank you, Dr. Lin, put this all together for us for this morning CME credit.
All the speakers this morning.
We appreciate you very much. Come here, Dr. Lin.
Okay. Project 个剪掉。All right. Okay. 1, 2, 3. 来，靠回去。
Hello, speaker.
用 speaker 讲啦。
朱正一、王站长、华理。
All the speakers, please come on the front. We want to take a picture together. All the speakers, please. 啊，都。
无还有啥物人？迄个朱正一，
连长张主任、王站长。
我给我号。哎，叫伊来你。
Hello， 有啊，很好声，啊，你有这个有无你咯吼，主持人看没一个，因为咯，看没看没换来换去，啊无，另外一个讲话对吧？另外主持人对吧？较过来哈，麻烦。
来，较中的，较中的。来，较中。来，较中的，较中的。In the center.
Hello， 安尼是。Hello。
目前破没谁搞，那。啊，不开台面啊。啊，安尼啥。Okay, that's good.
好，这位先生，来躺出来。
All right, here. Look at me. 1, 2, 1, 2, 3. Okay. 我叫。
Next team. Now smile.